implants.
Thank you, Arup. So we'll have some time after the next presentation. I think if you have any questions after the next presentation, you can have the questions ready. Ocular implants bypass blood-retinal barrier. The concept delivering drug below toxic level and at higher dose rate without any systemic side effects. Subconjunctival implants for anterior segment instilled through small incision. Intravitreal and suprachoroidal implants used for posterior segment. Intrascleral for anterior and posterior segment inserted then through the 1.5 scleral thickness pocket and closed, and devices non-biodegradable and biodegradable. Non-biodegradable implants, intravitreal, intrascleral, or iontophoretic, better than topical and systemic in giving high drug levels, but susceptible to rapid clearance in hours. Frequent dosage required. Sustained release drug system, decreased frequency in application and complication, and no initial burst. Sustained release drug system, nanoparticles, microparticles, and liposomes. Made with pelleted drug care surrounded by non-reactive substance, the EVA and the PVA. The biodegradable implants, to minimize the complication of surgical implants, biodegradable implants came into play, mostly used for acute onset of eye disease requiring loading and tapering dose. And biodegradable implants, rods, discs, pellets, plugs, and sheets, polymers available, polylactic acid, polyglycolic acid, polylactic co-glycolic acid, polycaprolactone, and polymethylene malonate. Polymers used, PLA and PLGA. An advantage over non-biodegradable replacement, flexibility of dosage, short duration in weeks and long duration in months or years. Biodegradable implants can be used for a smaller incision and multi-drug dosages. In the treatment PVR, PGLA matrix of 5FU, TA and TPA, the size was 7 or a 0.8 millimeter cylinder with 3 layers, and the multi-drug treatment, dexamethasone for uveitis and DME by Ozurdex, and the SR dexamethasone is made of PLGA matrix. Now it's in phase 3 DME due to retinal vein occlusion. And phase 2A, significant improvement in visual acuity, retinal thickness, and fluorescent leak with minimal SE, vitreous management, and the intraocular pressure rise. And the phase 2B, sutureless with 22 gauge needle, no vitreous surgery, and there's an increase in IOP. Steroids. The corticosteroids are a class of drug that has been used by a variety of roles for many years for ocular medical indications, and more recently in the posterior segment, and as a primary therapy to improve the response to surgical intervention or to enhance therapeutic agents as an adjunctive measure. And actions: decrease VEGF production, widespread anti-inflammatory effects, more rapid onset and rare and more profound initial effects on edema than anti-VEGF, and the side effects are cataract and glaucoma. So the steroid implants available are fluocinolone acetonide, triamcinolone acetonide, and dexamethasone. These are the various steroids available. The fluocinolone acetonide is the Retisert for the chronic non-infectious uveitis, biodegradable implant marketed as Illuvian, and the fluorescent angiography in diabetic retinopathy, 57% decreased macular edema and retinal thickness to 20% of control, and fluorescent angiography in CRV at 12 months, visual acuity 20 by 60 from base, 20 by 126, and central foveal thickness 622 micron to 199 micron. The triamcinolone acetonide is useful as an anti-angiogenic in neovascular and proliferative ischemic retinopathy eyes and exudative AMD. And the STRIDE, the sustained triamcinolone release for inhibition of the diabetic macular adhesion. The triamcinolone versus focal or the grid laser, the DRCR study group with the 80-40 eyes report showed superiority of laser treatment over 2 years of follow-up. 79% of eyes were phakic at start, and IVTA dosing interval was less or more than 4 months. Combination IVTA with focal laser, the DRCR protocol, this was the mean best corrected visual acuity, and that was the mean central macular thickness. And this showed the various the triamcinolone options. And then the Ozurdex made study group 2014, The purpose was to evaluate the safety and efficacy of dexamethasone intravitreal implant, Ozurdex, in the treatment of patients with the diabetic macular edema. Designed two randomized, multicenter masked, sham control phase 3 clinical trials with identical protocols were conducted. Data were pooled for analysis. Participant patients number were 1045 with diabetic macular edema, best corrected visual acuity of 20 by 50 to 20 by 200, Snellen equivalent, and central retinal thickness of more than or equal to 300 micron by OCT. The main outcome measures, the dexamethasone implant 0.7 milligram and 0.3 milligram met the primary efficacy endpoint for improvement in best corrected visual acuity. The safety profile was acceptable and consistent with the previous report. The fluorescein acetate in diabetic macular edema, the FAME extension study 2012, the objective was to assess the efficacy and safety of intravitreal inserts releasing 0.2 microgram per day, low dose of or 0.5 microgram per day, high dose fluorescein acetate in patients with diabetic macular edema. The designed two parallel prospective randomized sham injection controlled double masked multicentric clinical trials. And the participants subject with persistent diabetic macular edema, despite at least one macular laser treatment, were randomized 1:2:2 to sham injection of 185, low dose insert in 375 patients, or high dose insert in 393. The main outcome measures, the primary outcome was the percentage of patients with improvement from baseline best corrected visual acuity in early treatment diabetic retinopathy trial, letter score of 15 or more at month 24. Secondary outcomes included other parameters of visual function and foveal thickness. The conclusions, the both low and high dose FA inserts significantly improved best corrected visual acuity in patients with DME over 2 years, and the risk to benefit ratio was superior to the low dose insert. And this is the first pharmacology treatment that can be administered by an outpatient injection to provide substantial benefit in patients with diabetic macular edema for at least 2 years. The risk factors, glaucoma, the OHT, the steroid response, young age, higher loading dose. It shows the any IOP medication as well as the surgery for the IOP. So the pseudophakic, non-glaucoma suspect eyes, the ACIOL consider avoiding an implant. Post-vitrectomy consider avoiding IVTA. Prior glaucoma surgery offers limited protection against steroid intraocular pressure response. The diabetic macular edema resistant to anti-VEGF or laser, macula-threatening exudate, the one-time use for DME prior to surgery, PRP laser, and cataract surgery. The triamcinolone is less expensive, the Kenalog more frequent injection, greater peak trough effect, steroid implant more expensive, fewer injections, better pharmacokinetics. We have the Ozurdex here. The Bevodex study, in the 1 year result of RCT, bevacizumab versus dexamethasone. Dexamethasone has superior functional and anatomic outcomes in pseudophakic eyes, and the mean number of injection is 3.7 dexamethasone injection and 8.6 bevacizumab injection. I'll just show you our study of drums, just a few slides, just to where thanks to Dr. Rajiv Raman and Dr. Kumar Manikvel, who has helped us in setting up this Aditya Jyot diabetic retinopathy urban Mumbai study.